Good afternoon and welcome to the next in our series of in-live conversations webinars. My name is Manoharan. I'm the AMA Queensland Vice President, and today we're talking about palliative care, especially interesting with the impending legislation to be put before our Queensland Parliament in May, seeking to legalise voluntary assisted dying. Today I'm joined with Shyla Mills, who is the CEO at Palliative Care Queensland. Hi, Shyla.
Hi, thanks for having me.
Thanks for being here. So Shyla has worked in palliative care as a nurse, an educator, and national program manager for over 20 years, and has been the CEO of Queensland's and the peak body and leading charity for palliative care since 2017. She has a special interest in palliative care strategy and policy, public health palliative care, as well as death and compassion literacy. So welcome, Shyla. Thank you for joining us in conversation today to talk about palliative care. I'd love to know a little bit more about you. So you've worked in palliative care across a number of settings, including paediatrics in the community and aged care throughout Australia, but also internationally in Nepal and India and Mongolia. Tell us a little bit more about that.
Yeah, thanks for having a chance to have this conversation on such an important topic. So I did my nursing down in Adelaide originally and worked over in Perth for a while and also in Melbourne, and then went overseas and volunteered. So I volunteered in India, Nepal, Mongolia, and then worked in UK and went back after I'd earned a bit of money and went back to the Asian countries. And so, yeah, it's completely different, obviously, in different countries, how palliative care operates and, you know, how the public health system works in different places. But it's interesting to see. I think one of my biggest lessons that I learned overseas was really, particularly in India, Kerala is an amazing, one of the leaders in public health palliative care on an international stage. And that's because they have their community that works with them, with the health system really closely, and they help them identify when people are struggling or people need extra care and support, and then they signpost or navigate them to support systems. So we'd love to integrate that in Australia too.
Wow, that's fascinating, because look, I don't think a lot of people look at India and think about, you know, being a world leader in some aspects of healthcare, but really when you have these large populations, it becomes an important part of death and dying, really.
Exactly. And one of the things they did there is they trained all the bus drivers up into sort of system navigators or palliative care navigators. And so they helped to see, because that's their main transport system. So they could identify when people were struggling and support them on to sort of extra supports or link them to community volunteers, all of that sort of thing. So it's a great concept. And that's what we're really looking at here. We call it compassionate communities. So how do we build networks of support around people at the end of life?
That's interesting. So one of the things I just picked up on is when we talk about these terms, so we've talked about palliative care, there's, and the other term we've heard a lot is end of life care and dying with dignity. And there's a few of these words. And so we're talking to a group of health professionals at the moment. What are the differences between these terms and how would you use them in your clinical practice?
Great question. I think for me, it's quite confusing to a lot of people, and particularly to the consumer. And I guess when people are at the end stage of life, or have a terminal illness or are grieving, it's quite hard when they don't understand the language we use in the system. So we often recommend to people to demystify and simplify what you're talking about. So really go back to talking about last days, weeks, months, years, or are people grieving? And I think then people know what you're talking about. We're using their language in the space. I think end of life, really that language around end of life is quite confusing in the health system. Some people think of that as terminal phase care, like last days of life, and other people think of it as the last year of life or so in that space. So we have had feedback from some paramedics that they've had people from aged care facilities ring up and say, I have a patient that's at end of life. And they're not quite sure, are you meaning the last few days of life or are you meaning the last year of life? And so that's why we really recommend to simplify it and just say, you know, they're in their last days or they're in their last weeks, months. And we don't say go down to, you know, for their last 10 days or anything like that, just days to weeks, months to years, you know, those sort of language is really something that's friendly for everyone in the space. From a palliative care point of view, that's really should be available for people once they are diagnosed with a life-limiting condition. So lots of people are still on curative pathways in that space, and palliative care is still relevant in that space for them. I'll give an example of that, particularly in paediatric pal care. So say if a child's being diagnosed with leukemia, sometimes they have a palliative care team in there during diagnosis, and they say, you know, there might be an 80–90% cure rate. But I'll bet you, and I've got kids, if this happened to me, I'd instantly go to that 10% and think, well, what would happen there? So that's where palliative care teams are great to demystify, ask questions in that space, and then get on with your treatment journey. But know that palliative care is going to be there if you need them at any time.
Yeah, I feel like as a clinician, sometimes we feel a little bit uncomfortable talking about death to our patients, especially if that's the first they've heard about it. It might be a new diagnosis. And talking about, it might be something to do with us not understanding it inherently, but also being uncomfortable about giving bad news to patients about their life, really. How do you think we should navigate that? Are there resources that, you know, Palliative Care Queensland can recommend that clinicians can use?
Yeah, there's lots of great resources, and actually Queensland Health has a lot of good ones too. Which we can share with you and you can share with people listening today. But I think a particular thing when you're talking about death and dying is to be comfortable within yourself first. So I think reflecting on what your own opinions are in this space, how that would feel to you, how you'd like your family to listen and think about it in your space. And then once you're a bit more comfortable with it, it's a bit easier then to talk about that to other people. And I'm not recommending to put your own views on other people, but I think just that reflective practice for yourself first before you discuss it with other people is really critical. A little bit like advanced care planning, we really encourage people to do their own before you go chat to someone else, so you know what they're going through, and it helps you put yourself in the patient's shoes as well.
Yes, it's funny you brought that up, because in my experience, we always tell our patients about, you know, make sure you have your EPOA and look into advanced care planning. But when I was having that conversation with my own parents, it's very confronting. It is very difficult to do.
Exactly. My father at the moment is currently has kidney failure, and having those discussions with him, he's a retired GP even, and having those discussions with him is challenging, definitely. But I do think probably one thing people don't think about with palliative care is really that it's about living. Yep. So it's about knowing that there is a shorter lifespan for you. So what's important? What matters most to you now? And how do we support you to make that happen as much as possible? And I think if people think about that, I think we talk about breaking bad news in palliative care, but actually we're talking to people about this so that they can prepare and know what's important to them and give them that insight into refocusing. And, you know, maybe your job is not the most important thing at this point, then maybe you want to go and see your family, or maybe there's other things that's important. So if you do have just a short amount of time left, it gives them the blessing to know that they can refocus what's important in life. So maybe framing it in that sense for yourselves, then before you give the prognosis discussions, then that might be an easier way to think of it.
Oh, that's really good. Good to hear. You talked about living. Let's change the conversation to dying. So AMAQ has been lobbying the Queensland government about funding palliative care adequately before the legislation for voluntary assisted dying is passed, or is going to be put to Parliament in May. And all indications suggest that it probably is going to be passed, looking at the political will at the moment. So in our recent survey of voluntary assisted dying to our members, we asked if doctors should be able to offer accessible palliative care options prior or at the same time as offering voluntary assisted dying. It probably is no surprise to you and to our listeners that it was a very strong response in agreement with that. So we're 98% of the 1,200 doctors that responded saying yes. So that's very strong support indeed. So what are your thoughts on voluntary assisted dying in the context of palliative care?
Great question. I think, again, voluntary assisted dying has a lot of emotion tied up with it. And I think that's one of the key things that when you look at the media and the way community responds to it, that is one of the challenges, that emotion tied to it. I think from a health perspective, we can really break it down to actually what does this look like in the context of service delivery or support for a family or care delivery. So really, if you think about it, when someone's diagnosed with a life-limiting condition, they should at that point have access to palliative care, or the ability to have access to palliative care. And then it's about then their treatment journey or their care journey into the next phase of while they're undergoing the care that they're getting at that point. So if they feel that they've got intolerable suffering, and if VAD was legalised, then at that point they might ask for that. And I guess one of the key things that we would really encourage in palliative care, they might ask for VAD, but I guess the question is, tell me about that intolerable suffering. So it's easy to jump to a solution, but actually what we need to talk about is intolerable suffering. And that's the reason why they're asking for it first. And that's a very tough conversation for a lot of people, and we're very busy. So jumping straight into a solution is easy, but that question is really important to understand what is it that's triggering this and how do we support you in that? And it might be other things. It could be simple things that we never know, and maybe we can look into that with them. So it could be pain relief, it could be issues in that space, symptom management, it could be existential questions, or it could be that they feel like they're a burden to their family and that's why they need it. So if we can delve into that with them, that would actually be really beneficial, I think, in the case. And then if we continue on the journey, I guess, so if they do choose to go into, to look into VAD and it is legalised, then they would they would get an assessment at that point. So all that time they need palliative care with them while they're being assessed from the VAD team. They need palliative care to support them on their journey. And then the VAD team would decide, are you eligible or not? If you're not eligible, then you still need palliative care. If you are eligible, then you'll go through the planning process, I guess. And while you're planning, you need palliative care during that stage, right up to the end moment where palliative care would not deliver VAD. That's not our role as a profession, but the VAD team would do that. And that would be that procedure, I guess, at that point. And then palliative care would need to be there for the family after for bereavement support in that space. So that's on a process point of view, if you just sort of think about it like that. And I guess the big thing for us is we don't have capacity in the palliative care sector to provide that currently at the moment. We're not able to provide it for every Queenslander from diagnosis to bereavement across the whole state when and where they need it. So we don't already have that. And we know there is a massive gap in that space. So adding VAD into it, if people don't have the choice for palliative care, but they have the choice for VAD, that's not ideal in the health system.
Absolutely. And I do want to come back and talk about funding and current funding. But before we move on to that, I just want to talk a little bit more about voluntary assisted dying. So I completely agree with you. I think VAD is a tool that can be used in amongst other resources in delivering palliative care. And it's not done by the same teams, and we need to define who does that and how does it occur. A lot of that we will do, I'm presuming, through the legislation in May. We have, the AMA Queensland has put our submission through about where it thinks doctors should have the ability to influence and impact in that legislation. We absolutely need to be on the table for that discussion. It's a societal decision, really, but we need to be there once the care of these humans really are transferred to us to manage, and they're trusting us with their end of life processes. We need to be involved in that. I am very interested to explore what we currently do for patients who are suffering, especially in acute care settings in hospitals. There's a doctrine of double effect. So we often give our patients medications or other supports to help ease their comfort. And sometimes, as a secondary result of those medications, they might pass away. And that's currently protected under legislation. How is VAD different to that?
Well, so VAD is a deliberate act and it's an informed act. So they're very aware about the purpose behind it. And I guess the big thing, you mentioned before about VAD being part of palliative care. I guess just to reinforce, it's very different. We feel in palliative care, it's very different. Palliative care does not hasten death. So that's one of the key differentiations in the space. So our purpose is to provide that wraparound support, looking at health, social, emotional and spiritual support for someone throughout that journey. But we don't hasten death. We provide symptom management and holistic support teams around them at that point. But the actual time of death, we can never get that perfect. We never exactly know when that is. And I guess that's where VAD would play a role for some people. They want that control to that point where they know exactly when they're going to die. And that's not something palliative care does. However, I guess I have seen many patients that even now when it's not legalised that, say they've gone overseas to look into this in different stages. And I would say, and most of my colleagues would say, that when you have that wraparound support available from very early in your diagnosis, and it's a needs-based model, so palliative care can support you on a needs-based model, working with your existing teams in that space and with the family and their community, most people would not need it at the end, because they've actually got that support and then they want to focus on living. Oh, hang on, I want every day that I've got left to actually be as good as it can be. And they start focusing on the positives of life in that space rather than focusing on the intolerable suffering as well. So I think that's the main thing that people don't realise in VAD. I think it's definitely something people want from a control perspective. And I think we have to think a bit about society in that space, and that is how things are moving in the space. So that's probably why it's such an interest, that they want that control. But again, a lot of people probably will be eligible for it, but wouldn't even uptake it, I guess, in the end. And that's what we're seeing in the international literature. It's about having that control or that option, additional choices of care, but not always actually using it in the end. And I guess our point of view is, if we're going to focus so much money and time and effort onto that, but not on palliative care, which is for 100% of the population, really we need to sort of shift the thinking into palliative care and ensure that's considered in the big picture.
So go one last question before we move on to funding. So we know that palliative care is underfunded. So if you have a number of options in front of you as a consumer for any treatment or for anything else in healthcare, and the wait list or the accessibility of one of those options is limited, it's almost a choice made for you in some regard. And so if VAD is one of those choices, are you worried about a coercive effect that might have on consumers?
It's definitely a potential, I think. Yeah, we know that, you know, palliative care, people want to die at home. People want to have their family around them. We ask people what matters most to you at the end of life, and majority of people always say family. You know, family is what matters most to me. So if we don't have a system that can provide care when and where they need it, then it does limit your care choices, definitely.
Okay. So let's move on to the funding. So we at AMAQ, we placed palliative care as one of our key priorities in the 2021 pre-budget submission. And we're calling on our government to provide an additional $275 million per year on top of the $110 million that's been allocated, really to address that unmet need in palliative care in Queensland and allow access to dying with dignity and palliative care. And we did this in conjunction with groups like yours. So can you help us understand why we need this level of funding and what it actually achieves?
I just refer with the dying with dignity, you're talking about palliative care as dying with dignity rather than the organisation that most people think of.
Yeah, just
reiterating that, because it's a bit confusing. I guess we do say in palliative care that palliative care helps people have dignity. So it is a bit confusing, that language. And we try to own the word as well. So it's great to hear that. So yes, I guess the big thing for us is we worked with the Queensland medical directors and our members as well. And we costed out, what does palliative care look like to the level of the World Health definition in Queensland? What do we currently have? What's missing? And that's where we did that analysis, and we came up with, well, we need another 275 million per year. Now that's divided in two arms. Majority of it's in service delivery, the gaps in service delivery, but there's also a percentage in capacity building that needs to happen across the state as well, so that we've got a sustainable model of palliative care and we can deliver it across the areas as well. So workforce is a big challenge. We all know we definitely do not have enough doctors, nurses, social workers, admin, volunteer teams, everything across the state. But it's not just like we can just put dollars into that. We actually need to train them and do the system building behind it, a workforce building plan, work with the universities as well. So there's a lot we need to think about in this space, but we've really done an amazing job. It's the first time ever, I think, we've seen it being done, where we've really gone very detailed in what is needed. And that's where we've come up with that 275 million per year new money. So you'll notice the government announced last year, or the current Labor government announced last year as part of their election promise, the 171 million over 6 years. So I guess the disappointment for us was the 6 years aspect to it. And obviously breaking that down is not anywhere near what we costed out is needed in the state. And so, and now we're trying to get some understanding of how that breakdown actually works, and also to advocate that we need more than that. You know, that's really not going to answer the issues that were raised during the inquiry, during the palliative care inquiry. You know, palliative care is part of aged care. Look at the Royal Commission results. You know, we need to really look at palliative care properly and deep dive into looking at long-term solutions in this space, because we had an inquiry about 10 years ago and really only probably 1.5 of those recommendations were actually implemented in that time. And most of the results of this inquiry are very similar to that. So it's an obvious thing it's needed. And we know that palliative care is probably not the sexiest part of the healthcare system. We're not the emergency and ICU where most people focus on. We're about the sad part for a lot of people think of us in that space, and it's not easy to go there, but it's important. And we always say you know, the way we care for our dying is a significant indicator of the kind of society we are. So we need to think about power care too, and they need to really invest in it.
Absolutely, compassion is and you know, is part of our profession.
Yeah.
And it's fascinating that you're getting 10% of what was requested and what's required, by sounds of it, in Queensland to deliver palliative care. And I think, you know, in this coronavirus sort of era that we live in, we've really had to rethink our attitudes towards rationing in the healthcare system. So, you know, 2 years ago, talking about, you know, the types of patients who may or may not be given access to ICU beds, I mean, that was taboo.
Yeah.
But we've had to face those realities. Perhaps not as profoundly as in the UK and other countries with multiple outbreaks and large outbreaks, but certainly in Australia we've had those conversations, and you would think that our attitudes about that have changed somewhat, but it seems like we're still struggling to look at the normal dying process and how we facilitate comfort and support in that space. So when we're talking about this 10% of the funding we're going to get, how do we prioritize it? What's important? Do we need to focus on in-hospital services? Do we need to focus on community services? What are we going to do with that money?
Yeah, well, I think one of the challenges is in the space is people want to die at home. We know there's hospital ramping and capacity issues within health systems. Now, it seems like a logical concept to go, well, people want to die at home, so you're talking about community. We can work with community to answer our patients' needs, and maybe we could build up that at-home palliative care supports across the state. We will always need specialist supports in palliative care units in hospital settings as well, because it's becoming more and more complex, a lot of the palliative care symptom management, particularly when you're talking about people that have had complex cancer treatments and things. So there is definitely the complex needs that you have in a hospital setting as well. But a lot of people can die at home and get excellent services in their home or in their local community. And if logically, it's probably a quite clever health economics thing to consider reframing palliative care into that community setting, really providing intense palliative care support in that space, working with generalist care, because a lot of palliative care can be provided by generalist teams. So specialists provide that complex and persistent symptom management and support, but generalist health services and supports and staff, we should all be providing palliative care. So it's everyone's business, is our theory. You know, palliative care is for everyone. All of our patients will die at one point. Not everyone will require palliative care, but the vast majority will. So everyone in the healthcare system does need to understand what palliative care is and how they can provide generalist palliative care. So we should all have it in our system and training in that space as well.
So before I ask my next few questions, if there is anyone online who'd like to ask a question, please send it through in the chat, and we can put those to Shyla whilst we've got her. So going back to the concept of community palliative care, so we like to talk about the primacy of primary care and the primacy of having a GP and a GP who looks after you throughout, you know, all the conditions in your life. And you know, get a GP is what we tell our doctors here, and I'm sure, you know, it's a message we are encouraging with our patients as well. Where do you think GPs fit into provision of palliative care?
Central, very central to the whole model. Definitely, GPs are a huge part of palliative care. And I guess it is hard though for GPs in the current model of care that we have, because palliative care is mainly a home base. They're a bit too sick to get into GP practices often. So that's hard, you know, in the current system. And like I mentioned, my father was a GP, so I definitely know what the challenges are when you've got a patient load of 15-minute blocks. You know, how do you get to a home visit in the middle of that? So really, palliative care is a team approach. It's working really collaboratively in a holistic team to provide that care. Central to that team is the carer. You know, they are the ones that are key there all the time providing that care. And we've got some amazing new initiatives happening in Queensland in this space, which supports the generalist palliative care providers through the specialists. So we have a program called Sparta, which is a new hub and spoke model of palliative care, supporting the more regional areas. There's a Palli Consult service that is a phone call service that generalists can ring to talk to a specialist palliative care doctor or nurse to provide that support. So generalists are key to palliative care because, like I said, not everyone has complex and persistent issues in palliative care. So generalists should be providing the majority of the care. However, we know because there hasn't been a lot of training in that space or system set up, that that's very hard for people to do, and that's why specialists normally provide that care. But everyone should be providing palliative care, and then the specialists do the support mechanism for people or help people when they are in that complex stage. So I think we often say, I'll refer you to palliative care. And I think the thing for us to really reiterate is we can all provide palliative care. Some people will need referrals for complex issues, but not everyone needs that. And that's where we can provide that support, and particularly aged care and those sort of areas as well.
Yeah. So I guess we've talked a lot about what we can do as healthcare providers. And I know you were involved in the Ambulance Wish initiative. And, you know, I remember watching the news once, and there was a lovely old lady who wanted to go watch a sunset. And the ambulance officers took her to the beach and let her watch that sunset on her way to her respite care before she passed. What's the importance of looking after what our consumers want as well in all of this?
It's integral. It's the only thing that really matters in the space. So I guess that's the, what do I say, privilege of palliative care. There is obviously the complex medical support that we provide people, but a lot of it is just that simple question: what matters most to you? So today, what matters most to us might be different if I have a life-limiting condition. And what matters most is what we've got to ask our patients constantly. What's important to you? What matters most? And I guess, so Ambulance Wish is a great example of that. And to be honest, it shocked us a bit, the level of engagement with the program. So we launched it as a little program in Queensland, first to bring it to Australia. And we launched it for the concept of, we like fulfilling wishes, and it's almost a social plug-in to palliative care services. It gives them that option. However, we never thought the community engagement, and, you know, most people don't talk about palliative care, but we've been on Sunrise and all the TV shows, and the news follows it every time there's a good news story. And they're talking about palliative care, because really what palliative care is what's important to you. How do we get this team around you to support you to get to fulfill those goals of care? And palliative care, I mean, an ambulance wish is simply a description of one. So it might be to go to the beach, or it might be an ice cream, or to go to the AFL football, or the Gabba the other day we did one. So that's an example of what matters most, and getting a team around them to do what matters most. My dream would be the aged care facilities and schools collaborate, and schools work with aged care facilities to help them fulfill wishes. You know, couldn't we all do it? Not everyone needs an ambulance. You know, the ambulance wish is about people that require mobility support, but lots of people are at that end stage of life and they've got wishes that they'd like to see. We could deliver wishes to them. Society could be a big part of this, and that might just change how people think about the space.
So going on from that, so we're talking about, you know, you mentioned schools and how people think about death and dying. Let's talk about the concept of palliative care and public health. So what do you think about society's views on death and dying at the moment? And do you think that palliative care could be operating in the space of public health?
Definitely. So I've done a Masters of Palliative Care and a Masters in Public Health, and people used to think that's an oxymoron in the space. And I guess there is a big movement in the space, and it's called Public Health Palliative Care, and there's an international organisation, and Australia is actually one of the leading groups internationally in this space. And so really, when you look at a health promotion, for example, look at most of our health promotion is don't drink or you'll die, don't drive fast or you'll die. All of it ends up dying, you know, in a very negative frame. And we say, well, dying's not that bad. You know, dying is a part of life. It's a guarantee for all of us. So maybe we can die well. And maybe if we have early conversations, we do advanced care planning, we talk to our family openly about this space, we can actually die well. And then it's not a negative outcome. So that's what health promoting palliative care is opening up conversations in this space. And we did do some Good Life, Good Death expos at the Brisbane Convention Centre and up in Townsville as well. We thought, who's going to come to this space? And we had 1,000 people in 2 days come along and talk about it very openly. People are okay to talk about this space because it's a fact of life. So we really encourage people not to think of palliative care as needing to be resilient to palliative care. We should take a wellness approach. It's a fact of life. And how do we integrate this throughout our life to know it will happen one day, and that's okay.
is there a point where it's too young to be talking to people about this? Like, should I be encouraging all my GP colleagues to be asking their 20-year-old patients about, you know, their wishes and what they want in life? Is that too early?
Never too early. I've got a 8 and 10-year-old son. They're very well versed in palliative care. They often talk about it, and they know exactly what it's about. And I don't think there's any problems, because it's a fact of life. Grandparents die, family die, death and dying is just part of life. And I think it's demystifying it. To be honest, with children, they often have a bigger imagination about a terrible death because they've seen TV shows and video games, and that's what they think dying is. So we do encourage people to really have open conversations with children, people of all ages, because usually what goes on in their head is actually worse than reality. So it's definitely important to have that conversation. And advanced care planning, we'd encourage GPs to talk to people from, you know, 18 onwards, just every couple of years, just bring it up. Because palliative care, you actually have a bit of a privilege of knowing you have a shorter time left, but there's lots of trauma deaths that people have and other accidents that happen in life where all of that documentation and that forward thinking about what's important to you, making sure your EPOA knows what's important to you, is important for everyone. So even if you're palliative or you're thinking other issues are going on, we would encourage everyone to consider talking about this from an early phase and to be confident in talking about it.
I've got a question here from one of the viewers. So next week is Advanced Healthcare Planning Week. I'm in my mid-40s. Should I have a plan, and why?
Very good question. So yes, Advanced Care Planning Week is next week, so very important week. And the other big week is National Palliative Care Week in May. So we're very lucky in Queensland. We have an Office of Advanced Care Planning funded by Queensland Health, run out of Metro South. And I really encourage you to go to their website. They have one of the best tools we have in Australia on their site. So the short answer is yes. Like I just said in the question just before, no matter what, you need to consider advanced care planning. So what the big thing is, an everybody document is what we say. Everyone should have an EPOA, and I've started those discussions about what's important to you if you can't make decisions in this space. And that's not just palliative care, that is for injuries, other things, if you can't communicate yourself. So we would say, yes, everyone should try and do that. And the big document that we have in Queensland, which is absolutely lovely, is called a Statement of Choice. And that's on that Office of Advanced Care website. And it's a values-based document. So it really looks at what's important to you, what's important in your life, and helps you articulate that. I would also encourage everyone to do that, just to start that conversation. But also, it's not a one document put in the drawer and I never come back to it. This is about an ongoing, go back in a couple of years and check that again and have a glass of wine with your family, talk to them about it, because that's what's important. To be honest, one of the challenges in palliative care is when the family are not on the same page as the patients. So one of the biggest things that everyone can do is encourage that open conversation and dialogue to all settings in the family so that they all know what's happened. And then if you take that emotion out of it, they can get on with living because they all know what's important, and then we'll focus on the nice things.
I've certainly seen that in my clinical experience play out with organ donation, where there's been someone who's indicated an interest in being an organ donor, but because that conversation hasn't been had with their family at the time of their death, sometimes those wishes aren't fulfilled. And it can be quite sad to see, because one, we know that the issue with accessing organs for transplants, but also that someone's dying wish was not fulfilled because those around them in our current legislative framework can make that decision. So that's fascinating. We've got another question. I've recently heard a situation where palliative care was mentioned to a patient in a rushed and abrupt manner. What training is being provided to doctors, especially in an environment like oncology, where doctors would see this situation on a regular basis?
It's a good question, and it's busy. Like, I don't know about you, but we are very busy. Everyone is very busy at the moment. The health system is very busy. So not surprising, and it's no one's fault when it is done in that way. But I think the big thing is it's a big conversation, and it's not just a one-off conversation that needs to happen with people at this point. So it's starting the conversation, going back and checking in constantly with people. So training wise, there is some great training in those new models that are being rolled out across the across the state. So there's a there's a program called SPACE, and we love our abbreviations in the sector. That's Specialist Palliative Care and Aged Care, and they're doing some training support for people. There's also the Sparta project and the Palli consult that I mentioned. They can give you some advice on how to start these conversations and have a chat to some specialists about what do they recommend, and they'll give you some tips and hints in that space. There's also quite a few national training programs for palliative care that is available for health professionals across the state, and that can give you lots of good information. So I can send you some links about all that.
That'd be great. We would love to share that. And it's interesting, because one of my colleagues who works in palliative care was telling me about compassion fatigue, and the compassion fatigue that they sometimes are faced with, especially when they've had a big day, a big week. They've had a lot of patients that have, had poor outcomes, and they find that's their coping mechanism. And my advice there has always been, you need to look after your own well-being, because if you're being relied upon by these patients and their families to really support them, you need to be looking after yourself first. Yeah.
Integral self-care is a big part of palliative care, and there's actually a great tool that I can share as well called a self-care plan, and we really encourage health professionals to do self-care planning as part of their activities. Consider supervision. I know some palliative care teams actually do have clinical supervision for the interdisciplinary team to just chat about this, because often it's what happens with your patient can reflect on an emotional situation from your own life as well. It can bring up things. And that's okay. And for people to have that chance and that space to reflect on that. But self-care is really important in the palliative space, definitely.
Absolutely. So we've got a question around First Nations and cultural aspects of palliative care. So Queensland, we have a large land size, and we're also quite dispersed throughout that. The tyranny of distance is real. And we also have a multicultural society and a large First Nations population, which is often centralised in locations away from big health services. How do we manage that? How do we actually make culturally safe palliative care options available to those populations?
Yeah, it's so important. To be honest, this space is huge. And I think the big thing is palliative care is a needs-based model. So it's asking someone, what do you need? What's your issues? Assessing their needs and then providing that. So really cultural, linguistic, diverse First Nation support is the same. So the model doesn't change in itself because of that. But I think we often forget that, and we make assumptions of what they need. So really it's coming back to people and asking them what is important to you, what matters most, what's your goals of care, and how do we support you in that space? And then their culture will inform their goals of care in that space again. And I think the other thing is not to make assumptions of that they're from a particular culture and that is their belief. That is how they're wanting this ritual. So an example might be that some traditions or spiritual religious traditions may want to be buried within 24 hours of dying. But that might not be their particular tradition. That might be one that we just assume that is part of this religion. And so it's asking people what's important. And again, just coming back to the basics about having those conversations with people. First Nations is particularly an interesting area, and we're doing more and more in that space. We've actually just done a few consumer conversations with Indigenous populations or First Australians across the state, and looking at Torres Strait and Aboriginal. I think one of the big lessons that I learned from these discussions, that we're about to release a booklet about this soon, was one, ask them individually what's important to you, and what their history is and what their beliefs are in this space is really important. The other one is not to assume Aboriginal and Torres Strait Islander are the same. And I think one of the lessons that I've got is a lot of our booklets we put out in this space have Indigenous artwork on them, or Aboriginal artwork. And the people up in the Torres were telling me, we are people of the sea, we are different population groups. So really to consider that to them. And I think we do make assumptions and put First Nations together. And I think they're very different population groups, and even just different communities that are across the state. It's talking about them individually, what's important to you, and then how do we help you make that happen. But also really remembering spiritual care is a big part of palliative care, and that's really important for a lot of cultures.
I guess it's that avoiding a label and all the biases and the preconceptions that come with using a label. Yeah.
Exactly.
We have a question on from one of our viewers up in Mackay, who's an end-of-life doula. What do you think about end-of-life doulas filling out those gaps in palliative care?
Yep. Yep. So doulas, most people don't know of end-of-life doulas or death doulas, some people call them. So we know of obviously birth doulas. Most people know about that, but there is this growing movement in death doulas or end-of-life doulas at the other phase of life. We call it the bookends of life. So really the challenge at the moment with doulas is that they're not a regulated system and the training is not regulated. So it's an individual training model. I know they are looking at moving it to a Cert 4 model, and that would help a lot as part of the training. But at the moment, that is probably the biggest challenge for us in a health space because there's no regulation. And also they often charge money. So I think people have told me around $2,000 is the charge for the consumer. And I guess for us, it's a vulnerable population group. It's also, social workers could be providing that support in that space, but we do know there's gaps in the system. So, potentially they are filling that gap really well in that space. But I guess for the biggest issue for us is more just around the cost, the fact that they are not regulated industry and that they're charging money to a vulnerable population group. So I definitely think it's a potential really interesting role in the whole space of the end phase of life. But just at the moment, we're just having a look into that space. And we are organising, actually, we're the sort of leading a national conversation in this space, looking at a round table nationally around how this role fits into the community as well.
Yeah, and I guess in a system where these doulas might be value adding and filling in gaps, then there have some, there is some use and worth there. Perhaps we need to look at funding models to make sure that the cost isn't being transferred to the consumer, but rather being borne by, the population, because at the end of the day, it's our taxation money that we'll be looking to use. So, and if they're adding a service, and to be honest, I hadn't heard about a death doula or end of life doula, but I'm learning things today. I'm learning a lot of things today. So last question I've got here, given your experience of palliative care around the world, who does it best?
Big question. I think everyone does it differently. Let's go pretty neutral in that response. I think everyone does things differently. And I think we've got a lot to learn from colleagues internationally in this space. You mentioned COVID before, and we are extremely privileged in Australia that we didn't get to the level of a lot of other countries, because when people were dying of COVID, that is palliative care. If we had those numbers in Australia, I don't think we would have been prepared to provide excellent palliative care to people across Australia in that space. And that's what's needed. That's what would have been needed in that space. So our colleagues overseas, we're learning lots from them regularly, but that's the specialist and generalist health system working how we support people in that end phase of life. How do we connect them to their families? How do we support them through bereavement? Like we said, the funding gap is very prevalent in Queensland. We would not have been ready to respond to that thing. So I guess we need to consider this in this space about palliative care. We learn a lot from our international colleagues every day. Everyone does things differently and does really amazing things. And it is a localised model because it should be localised to your local community needs and a system wrap around there. But I guess everyone does it in their own way. We're very good in Queensland. We have a lot of hospices in Queensland. We're quite good in the southeast area of Queensland. We have 8 hospices, and that's more than any of the other states in Australia. So we do provide that community grown NGO hospice model as well in Queensland, which is a lovely model and based a lot like they do in the UK. We have amazing specialist palliative care units across the state as well that do incredible things. And the stories I hear from some stories that you hear in local communities in different areas about what GP or primary health nurses are doing is just amazing. So I think everyone can provide it in different ways. And as long as we learn from each other, that's the best thing.
Well, Shyla, look, we're actually 15 minutes over time. We've been having a great conversation, and look, we'll close it there. But I think the fact that we're having this conversation today in Australia, where in other parts of the world we're confronted with images of mass graves off New York, for example, and hospitals that are full and burning in the NHS system, I think we're very fortunate. And yes, there's a long way to go. Yes, we have to address the funding gaps, but we're sitting here in a very privileged position, aren't we, in Australia, that we can have this conversation. We can go to our government and say, this is what you need to do to make sure the system's robust. And so I think, there's a lot that we can achieve, and the AMA Queensland is very supportive of palliative care in Queensland. It's a key priority for us. And I'm really thankful that you've joined us today. Really appreciated it. Thank you.
Thank you so much. And thank you, everyone.
Thanks, everyone. Thanks for your time in joining us. And if you do have any further questions, put them in the chat and we'll try to get to them later.